All right. I am so honored to introduce today Dr. John Neustadt, founder and president of Nutritional Biochemistry Incorporated, and the number one Amazon bestselling author of Fracture Proof Your Bones, already on to its second edition. He has published 100+ medical articles and is known for translating research into practical next steps, which I really appreciate. Dr. Neustadt helps women and men reduce fracture risk and protect bone strength through evidence-based nutrition, lifestyle, and smarter conversations with their doctors. Oh, I'm so excited to have you today. Welcome.
Thank you. Thank you.
Yes. So you're the expert, and I want to maximize our time together. I'm going to kick us off with a question, but also feel free to pull this back if you feel like I'm jumping the gun on anything. But I like how you definitely have this different approach where you are very practical, but you're also very research driven. And what a wonderful pairing of both. And one of the things that you claim is this: stop chasing a better scan number and start reducing real world fracture risk. And I would love for you to tell our community, if you can dive into, what does that mean? What are we looking for out of that?
That's a great question. I mean, the biggest risk with losing bone density, with bones becoming weaker, is not the number on a test. It's whether or not somebody breaks a bone. If you're a woman with osteoporosis, there's up to a 36% chance that you're going to be dead within a year if you fracture a hip. And the range of estimates of mortality for hip fractures in women with osteoporosis, there is a range. It goes up to 36%. Most often cited as 20%. Regardless, it's a big number. For men with osteoporosis, although fewer men are affected by this condition, their risk of mortality overall is even greater than a woman's risk if they fracture their hip. And those people who do fracture with osteoporosis, over half of them never regain their pre-fracture level of pain-free life and mobility and the ability to enjoy the activities and the things that they love without being in pain and discomfort. And a significant percentage of those end up needing continued care because they struggle completing what we call the activities of daily living: brushing their teeth, dressing themselves, bathing themselves, going to the bathroom independently. And nobody wants that. Ideally, we're all living our lives in a way that promotes health span, promotes longevity, in a way where we can enjoy our grandkids and our activities and our lives well into our golden years without the pain and discomfort. Because what happens is chronic pain in the elderly is often caused by osteoporotic fractures. And in fact, a woman's risk of an osteoporotic fracture is equal to her combined risk of breast, uterine, and ovarian cancer. Every 30 seconds somewhere, someone with osteoporosis is breaking a bone. And fractures from bone loss account for more days spent in the hospital than other diseases like Parkinson's disease, breast cancer, and other diseases, diabetes. And in fact, if you have other conditions and you fracture, your risk of dying is even greater. So women with breast cancer, for example, who fracture a hip and end up in the hospital, they have about an 82% increased risk of dying compared to women with breast cancer who don't fracture. And in fact, globally, osteoporosis is second only to cardiovascular disease as a global health issue. And yet, despite all of that, there aren't these big campaigns. Got the breast cancer campaigns with the pink ribbon, and this is a really misdiagnosed, underdiagnosed, mistreated, in my opinion, condition, and that bears out in the research as well. And so I'm really passionate about, as you mentioned, practical solutions, but also not just looking at test numbers. Because what we find that a bone density test result only predicts about 44% of women who will break a bone and only 21% of men. And again, it's not the number on the test that's the biggest risk. It's, how well does that test predict somebody's likelihood of breaking a bone? And so every medical organization that has looked at the research, they have correctly concluded that fracture risk depends on factors largely other than bone density. And despite that, even today, 20 years after I've started down this path of educating myself and others about this issue, 20 years later, still the discussion in doctors' offices with patients almost exclusively focuses just on that number on the test instead of the patient sitting in front of them and talking about how people can reduce their risk using holistic evidence-based approaches that are that's in the research, peer-reviewed research. None of this stuff is things that I invented. If somebody picks up and reads my book, I mean, there are hundreds of research studies cited in that because I want people to be able to show their doctors to be able to read it and go to the citations and go to the research if they want to educate them more, because it's a blueprint of how people can create holistic bone health programs that make sense for them.
Mm-hmm. Oh, this is so beautifully stated and set up. Thank you. I love this. And let's just go to that doctor's visit for a minute, because I think this is where everyone's going to relate instantly. And that oftentimes, if they have been even prescribed that DEXA scan to get the bone density score number, I don't know if the physicians are scared, but there's this quick, then we prescribe something. And I have a question for you around that. What are your thoughts around, because you are holistic around this? Give us where your brain goes just with the number, knowing that we have so much more to discuss besides that number.
So let me just take a moment and discuss that test report that people are looking at, because I think that there's a lot of confusion and there's a lot of fear around getting that diagnosis and seeing the number. And I want to really clarify and demystify what that means. So when you're looking at a bone density test result, you're going to get two scores. One is a T score and one is a Z score. A T score compares your bone density to somebody in their 20s of the same sex and ethnicities. So if you're a 65-year-old Caucasian female, your T score compares your bone density to someone in their 20s who's also Caucasian and female. A Z score compares your bone density to somebody of your same age group. Right. So it's a little more apples to apples, and they're negative numbers. So if the more negative, the more bone density that you've lost, and they're reported in what's called standard deviation. So when you get a bone density test result of a T score of minus 2.5 or lower, that is technically osteoporosis. And then the doctor often will say, let me prescribe a medication. You need to be on a drug. You need to be on a medication. That may be appropriate. But what I like to do is educate people about what questions they should ask their doctor. And that's what I do in the book and the medication chapter. What questions should you be asking your doctor to ensure that you're getting the best possible recommendation that is going to actually give you the results that you're looking for? And here's an example. Every osteoporosis medication, FDA-approved medication, will improve bone density. But a bone density improvement on a test that is created by a drug is not an indication that that drug is reducing your fracture risk. Let that sink in for a moment. So what they're tracking is the bone density test number over time. They prescribe a medication. Even the American College of Clinical Endocrinology says change in the bone density test, if fractures are being reduced by the drug, only account for 20% of that reduction. So just tracking that number on the test really is not sufficient. You have to ask the question, has the medication been shown in somebody with my diagnosis and my medical history to prevent fractures? Not just improve bone density. That's the crucial question, because that's the goal. If, in fact, clinically, the technical definition of failing treatment, meaning the drug doesn't work for you, you have to break two bones until actually they decide technically, well, this medication isn't working. And so I think those are important things to understand. And there are different categories of medications that have different benefits and different risks. And just to understand how to navigate that is really important. But I think also importantly, in understanding and minimizing, or hopefully even eliminating the fear around that diagnosis, is to realize that this is not an emergency. So I have people come to me all the time with their bone density test results, and they're scared. And I understand that. It's a scary diagnosis. Many people have a loved one, a parent or grandparent who fractured a hip, and that was sort of the beginning of this downward spiral. And they're afraid of being able to continue enjoying the activities that they love in their life, and nobody wants to break a bone. But I tell them, let's take a few deep breaths, and let's put the bone density test result in its proper perspective. Like I mentioned, it only predicts 44% of women with osteoporosis will fracture, only 21% of men. This is not new. This is known. That study came out in 2008. In fact, since the 1990s, we've known that bone density test predicts less than half of people with osteoporosis will fracture. And then I orient them to things that are also predictive of fractures and what they can do to control and mitigate those risks, including improving bone density. We want to improve bone density. Absolutely. We want to see that number stabilize or ideally even go up. But it's important to also note on that test result in the report area towards the bottom, if people look at their test results, there'll be a 10-year fracture risk is typically reported. It's based on a computer algorithm called FRAX, and whatever information was entered into that. It's limited in terms of what it can evaluate in terms of a patient's fracture risk, but it will give you the 10-year fracture risk. And sometimes physicians will mention that, they'll focus on that, like, oh, you have a 10% risk of a fracture, you have a 12% risk, you have an 8% risk of fracture. Well, that's really looking at a very negative, anxiety-producing way of interpreting that. It is actually how it's written, so they're not inaccurate, but I think it's incomplete. I think a better way to look at it is say, well, okay, if that's true, if you have a 10% risk of fracturing in 10 years, that means you have a 90% risk that you're not going to break a bone in 10 years. And just having people realize that for a moment, really pointing that out, I think drops their cortisol. Like, okay, yes, this is important. Let's get on this. But it is important, but it's not an emergency. Again, there is time to educate yourself and to create a holistic bone health program that makes sense for you. Now, medications may or may not be part of that. That's an important discussion to have with your doctor, but ultimately it's somebody's decision whether they take a medication or not based on being educated and understanding their choices.
Oh, there's so much to unpack on all that. And where do I want to start? Because it depends on the person sitting in the office, is where I was initially going with this as you were describing it. Because you could have a 45-year-old who's coming in with some low bone density results, as well as a 60-year-old, 70-year-old, 80-year-old. And you would be taking that into consideration, right? As you're thinking, does this person need a medication? How long would they be on that medication? Because if I'm understanding this correctly, once somebody goes on a medication to strengthen bone, that it actually, yes, improves the number on the scans, but it doesn't mean that it long-term improves the bone, like that they actually can become more frail and break down the road. So if you have a younger individual, then it can put them at increased risk when by the time they're 60 or 70, or am I getting that wrong?
You're not getting it wrong, but I think it's a little bit of an incomplete picture. So first, if you're 45 years old and you get a bone density test result, the T-score doesn't matter. There's no reference range below 50. So it's not even an accurate test. You have to look at the Z-score. That is accurate for younger. And that'll tell you if you've got bone loss compared to somebody of your own age and gender and race. And so what that can help us understand. So for example, if you're a 45-year-old woman and you're still getting your periods, then we've got to look for secondary causes, other causes besides just the bone loss that occurs with the drop in estrogen with menopause. One of the most common things that's a big concern of mine that is frankly a blind spot in conventional medicine is medication-induced bone loss. There is a long list of medications that destroy bone, increase fall and fracture risk. And doctors are prescribing them. The most common medications that are prescribed are damaging bones, antidepressants. And within those, the most common category of antidepressants are those that increase serotonin, Lexapro, Prozac. Those damage bone. We know that for every 19 women on one of those medications now, for 1 to 5 years, the research shows we'll expect one of them to fracture. And proton pump inhibitors, acid blockers, also very commonly prescribed, also increases the risk of hip fractures. And in fact, there was a study that was done that looked at patients, women with osteoporosis who fractured a hip and ended up in the hospital, looked at the drugs they were taking for the 3 months prior to entering the hospital, and then what they left with. And what they found is that even when a medication was switched, the doctor switched them to another drug that basically did the same thing, maybe with a different mechanism of action. So there was no net benefit. 75% of those patients were on a medication when they fractured that increased their risk for osteoporosis, fractures, and falls. When they left, there was no net benefit, same amount. And so that's where self-education and people understanding and getting that list, for example, that's in my book in the chapter on medication-induced bone loss. I think it's called Check Your Medicine Cabinet, something like that is the chapter. That's important. You're going to be educating your doctors, frankly, because doctors don't know this information. And this is not my opinion. There have been studies that have been done about this. There was a study done in France, one done in, it was either Switzerland or Sweden. I don't think it's any different in the United States, asking why is this so mistreated and undertreated? Well, the problems are that doctors, when they get the bone density test results, are not sure how to interpret them. Then they're not sure about the strengths, the benefits, and the relative risks of the different medications and which ones would be best. They are not comfortable having the more nuanced and in-depth conversations around diet, lifestyle, and exercise. They're not educated in that. And then they don't have time. In the short visits, 7-10 minute visits that are allowed, there's just not time. And oftentimes osteoporosis is deprioritized because many times people come in with other conditions that they think are more dangerous and immediately pressing, like cardiovascular disease. And so they, in the limited time they have, they may focus on that. 95% of people who are eligible for a bone density test in the highest risk category, that is Medicare eligible patients, 65 years and older, 95% of them are not even getting screened with a bone density test.
Wow.
So that's the first thing, is to understand the risks, and you're going to have to advocate for yourself in many cases and ask for that bone density test.
That's incredible that gets missed as a baseline. When we think about colonoscopies happen after a certain age and mammograms, and that bone density piece feels like it should just be layered right in there too. And to hear that it's not.
It's simple. It's conventional. It's covered by insurance. It's not complicated. I mean, exposure to radiation is so low. It's less than a cross-country flight. I mean, to me, it's a no-brainer.
I totally agree. I love that you mentioned, I feel like when we give physicians all the grace in the world, I really do think it's a time thing. I think that most would love to take a deep dive into all these subcategories of risks and different ways to treat it, but they just don't have time. So I'm just reiterating what you said, that we really do have to be our own self-advocate.
And you're right, it is about time, but also, unfortunately, they're not getting the education and their medical training to have these discussions to begin with. They're just not the experts in nutritional approaches to health and wellness. I looked at the data on this about the medical education. Most physicians get less than one semester of any nutritional training in their entire 4 years of medical school and residency after that. And nutrition is not integrated into case reviews and case reports and treatment plans. They are not the experts in this, unfortunately. I think many of them would like to be. I have many friends that are conventionally trained doctors. They're wonderful people. They have incredibly big hearts. They want to do the right thing. Unfortunately, they're having to learn all of this on their own by going to seminars and learning all of this information that's in the research, because their medical school education failed them in a way, in the sense that they just aren't equipped to answer patients' important questions around these issues.
Right. I feel the same way, just even with the menopause piece, that doctors, if they did have any education, they're like, it was brief, and there's so much more. So now we're talking extra time and research and care level on their own to go out and really grasp that. And this is where I love podcasting, because we have this opportunity to do this together that at least plugs the idea into a listener's ear that, like, there's a resource out there that if I have family history of osteoporosis, if I already was worried about it, I can grab this book and just know some questions to ask, back to even the point of what medications am I currently on? Should I be worrying? So I love that. Thank you.
You're welcome. Yeah. And there are take action sections at the end of many of the chapters in the book where people can tell me they take the book to their doctor's appointments, or there's a workbook that they can download, a PDF where they can take the questions and take notes and write down the answers, or make lists of questions they want to ask and things that they're going to do. Because one of the challenges is it's very difficult to remember questions in a medical appointment, or to remember the answers. And so being organized is really important.
So important. And my women get a little nervous. It's one thing to be like, be your own self advocate. But then when you're in front of the physician who has a time constraint and maybe an opinion about something that you have a different opinion about, it gets a little, it's just hard. It can be nerve wracking. So just permission to our listeners to take in a sheet like that. I definitely want to utilize this nutrition component that you keep talking about. I love, where do you go with when you're going to educate somebody and we pull in just some nutrition talk?
So I ask very simple questions. To
Mhm.
me, it's no more complicated than if we're going to recommend something, has it been shown to reduce fractures? I mean, that's the bottom line. Yes, we'd love to see it improve bone density or be associated with better bone density or reduced osteoporosis risk, but has something either shown in prospective clinical trials to reduce fractures or epidemiological research to be associated with reduced fractures? And so there are a lot of recommendations for diets out there. Keto diet. I don't even know all of them that are out there,
Yeah.
but the Mediterranean dietary pattern has been studied for decades, 70, 80 years. I don't know one negative study
Mm.
conclusion from that dietary pattern. It's essentially a plant forward diet with plenty of whole fruits and vegetables, grains, lean proteins like chicken and fish. It's essentially the opposite of the standard American diet, very low in packaged foods, low in processed foods. That is associated with a 20% reduction in osteoporosis and a
Mm.
21% reduction in hip fracture risk. And the more somebody adheres to that diet, the greater the benefits across the board. I mean, it's been shown to be associated with reductions in cardiovascular disease, diabetes, obesity, cancer, death from cancer, all cause mortality, Parkinson's disease, dementia. I mean, on and on and on. Again, I don't know one negative study that showed anything, but I don't know any studies except positive studies in that, if I said that correctly. But
You did.
thank you.
Yes.
And so that's what I look at. And what I find though, and when I'm recommending this and working with patients for so long, is it's one thing to just say, oh, go eat this way, but people don't understand how to transition into eating that way. There
Mhm.
are recipe books and great resources out there on the internet of how to maybe cook Mediterranean, made a Mediterranean style snacks. But how do you go from a standard American diet, which right now, the average American, 60% of calories in the average American diet is from ultra processed foods. And even that has been associated with osteoporosis risk, and get them to more of a whole foods, plant forward diet. Well, most people, myself included, are living their lives habitually. We have to. I mean, they're grabbing the same foods day after day. We can't consciously focus and make every single decision during our day. We would go crazy. It's an evolutionary adaptation that we live based on habits. It makes it energetically easier for us to survive and go about our day. So it's about transitioning into new habits. And I teach people a process by which they can transition into eating this way over a period of time that makes sense for them, whether it's 4 weeks, 6 weeks, 8 weeks, because oftentimes it requires shopping differently, having different spices in the house, having different snacks, cooking differently. If you have a family, getting the family involved. And so transitioning into that slowly over a time period that makes sense where you can develop new habits is better, in my opinion, in my experience, than trying to make a radical change quickly. I mean, huge changes done overnight tend not to be sustainable. But what we know is just small changes done consistently over time can completely change the trajectory of your health and your life. And so I have people go through a process where they quantify the amount of dietary fiber they're getting per day without changing anything. Just write down what you're eating for a couple days. And there are resources in the book and great resources online. You just estimate approximately how many grams of total dietary fiber are you getting, because where is that found? It's found in fruits and vegetables, those whole foods that have the vitamins, the minerals, and the other plant nutrients that our bodies and our bones need to thrive. And the fiber itself that's in those foods is very healthy and helpful, also for the gut microbiome and also for the bones, because there's a gut bone connection. And so what I find oftentimes when people do that is they're shocked by basically how little whole foods they're eating. The other thing I have them focus on is protein. That's it, plants and protein. one of the things that's missing oftentimes in the recommendations for diet when it comes to bone health is the amount of protein that people should be getting.
Hmm.
What the research shows is that the US RDA for protein as people get older is insufficient to maintain bone mass and muscle mass because there's a phenomenon called anabolic resistance, meaning that you need higher amounts to create bone and to create muscle than maybe you needed when you were younger. And so I recommend people get at least 1.2 grams of protein per kilogram body weight per day, or in pounds, 0.6 grams of protein per pound of body weight per day. So take your weight, multiply it by 0.6. That's a minimum number of grams of protein I recommend people should be getting a day. And then I say, look, try and get like 10% more than that. And if that's challenging to get in your diet, then that's where supplement comes in. I believe that supplements should be used as the FDA intended, as a supplement to a healthy diet. Diet and lifestyle are always long-term foundation. Supplements are there to fill the gaps. And so focusing on that protein, a consensus statement came out a few years ago out of a bunch of different European medical organizations that 2 to 3% of bone mineral density can be attributed alone just to the amount of protein that people consume. And in fact, this is the one piece of the sort of bone health puzzle that is also often overlooked when it comes to nutrition, because we've got that bone density piece. That's the mineral component of bone, the calcium, the magnesium, and other minerals. Well, bone is a tissue. All tissues in the body are made up of different things. So there's more than just minerals in the bone. There are also, in bone, a lot of proteins. There are 180 to 200 proteins in bone, in addition to collagen. Bone collagen, or type 1 collagen, is a structural protein in bone. That's what gives bone its ultimate strength and quality. Bone collagen, strand for strand, is stronger than steel. And that's what the minerals actually bind to. So it gives that scaffolding for all of those minerals and that bone health. And so getting enough of that protein is really important. In fact, when I work with patients and they seem to be doing everything right, and their bone density tests are not going up or continue to go down, they haven't stabilized. When I talk to them and I review what they're doing, almost universally, what's happening is they're not getting enough protein. And as soon as they get that on board, along with the exercise, along with the other things that they're doing, that's when I start to see better benefits.
Oh, this is so good. I know, because I feel like everyone goes calcium. They're like all supplement with calcium. And you're like, hang on, fiber, whole foods, protein, all of this makes such a big difference. Thank you. Such different areas to guide people's attention than just this. And I've kind of heard some varying information now on even the calcium supplements. And do you find that not to be as big of a deal? Are you again more like, no, let's focus more on whole foods and fiber and
I
protein?
Ideally, people are getting all their calcium from diet. Like the
Mm-hmm.
USRDA for a nutrient, and I think this is one of the challenges out there, both clinically for doctors, but also in the general public. And it's really important to understand that the USRDA for a nutrient. So, for example, for calcium, it's 1,200 milligrams for women and 1,000 milligrams for men.
Mm-hmm.
Well, that is from all sources, diet and dietary supplements. I have people still coming to me and their doctor has recommended 1,200 milligrams, 1,500 milligrams of calcium as a dietary supplement, which, in my opinion, and based on the research, is way too much.
Mm.
The average American woman consumes 800 milligrams of calcium in her diet. And the average American man, about 1,000 milligrams in his diet. So for a woman, if she's eating like an average American and hopefully working with you or following the recommendations in my book or wherever else they're getting their health information, they're eating better than that, because we all know the US standard American diet is not great. But if they are eating about on average, they're getting 800 milligrams of calcium. So a supplement that has 400 milligrams of calcium is going to bridge that gap and get them to about that 1,200 milligram range. Getting more than 1,200 milligrams a day of calcium, there's no evidence that it provides any greater benefit when it comes to bone health. And for men, with the USRDA of 1,000 milligrams per day, and the average American man getting 1,000 milligrams in his diet,
Yeah.
a lot of men don't need extra calcium as
Yeah.
a dietary supplement. And I think it's similar with vitamin D. Vitamin D is great, and I'm a big fan of supplementing vitamin D. But first and foremost, I'm a fan of testing vitamin D to make
See where
sure
you're.
that you're where you're at.
Mhm.
So for bone health, what the research shows is that a vitamin D blood level of 30 to 44 nanograms per milliliter is associated with maximum hip fracture reduction and maximum fall reduction. And so getting to that level is really important. Now, people can consume about 2,000 international units of vitamin D per day as a supplement. It'll get most people to that range.
Mhm.
But maybe they're already at that range and they don't need extra. But also for other immune health and benefits, many doctors, myself included, do want that vitamin D blood level higher. So
Mhm.
even getting it higher is okay. But just when we're talking about bone health, that 30 to 44 nanogram per milliliter range is really important. Now, there isn't the same toxicity or risk profile as you get with excessive calcium by taking more vitamin D than 2,000 units per day. So taking, even if you're at that 30 to 44, even a little bit higher, taking some or extra vitamin D typically is not going to be a problem.
Mhm. Thank you. Yes, that was answered wonderfully. I have one more question on food, and then I really want to hit fitness too. I want to flip the grid here, and we're talking all the promotional of how to go healthier and those baby steps to maximize our bone health with food. What do you think's the most damaging piece of food that can be happening when people aren't paying attention? Is it the processed? Is it that it's causing inflammation? What are some of those huge watch outs of this is not going to end well?
That's a great question. And first, I'm not sure if this is what you're asking, but I oftentimes get asked, should I avoid food X or food Y, a specific food? For me, it's all
Hmm.
about the overall dietary pattern. So when we're talking about ultra processed foods, what the research seems to indicate, indicates to me is that once you get above about 10% of your calories from ultra processed foods a day, that's when you start getting lots of problems. So I think it's unrealistic in our society to completely avoid ultra processed foods. I think it's great, but I also like to live in reality, and people's lives are busy and convenience foods are helpful. So minimizing it is really important. But what the research shows is that when you're eating the standard American diet, what does it do? This dietary pattern, that unhealthy dietary pattern that's high in processed foods, high in fried foods, high in saturated fats, low in fruits and vegetables and whole grains. Well, it promotes inflammation. And that chronic inflammation, there's a direct gut bone connection.
Hmm.
So it promotes dysbiosis, unhealthy gut bacterial balance, and that contributes to chronic inflammation in the gut. Over time, that then damages the intestinal lining, and you get what is colloquially called in the general public leaky gut or hyperpermeable gut. And so there are a couple things that happen with that. One, the inflammatory chemicals that are created called cytokines will enter the bloodstream and they travel to the bone and they directly interact with bone cells. There are two metabolically active bone cells called osteoblasts and osteoclasts. The
Hmm.
osteoblasts build up new healthy bone, and the osteoclasts break down old, worn out bone in a process called bone remodeling, which we have to have. It's really important. About every 10 years, in fact, we have all new bone. It's been totally remodeled. But when you get osteoporosis, that balance is out of whack. It's imbalance. In fact, osteoporosis and bone loss is essentially a condition of imbalance where the destructive forces are winning. And our job is to try and rebalance the system and actually tilt it more towards building up healthy bone again, those osteoblast activity. Inflammation, those inflammatory chemicals, they go and they attach in the bone and they stimulate the osteoclast activity. So you get faster bone breakdown. And then what happens is you also then get these molecules, these hyperpermeable gut, you get immune activation because you've got these foreign particles that shouldn't be getting through the intestinal lining that are then stimulating the immune system saying we've got to go on overdrive, and it just sort of it's a feed forward system where then you get more inflammation happening. And then you also get a situation where you're ending up with reduced absorption and reduce digestion. And so it increases the people's risk of nutritional deficiencies. which are well documented and linked to bone loss, osteoporosis, and fracture risk.
And so you mentioned this with the osteoclast and osteoblast and how we're supposed to be rebuilding of bone. Back to my question with the osteoporosis medications. My understanding of those is that we no longer get the rebuilding of fresh bone, that it becomes more of a solid and fractured. It looks good because it looks more solid, but it's not doing what you're saying. It's not getting rid of, sloughing off the old bone and building new.
It depends on the type of medication. There are different categories of osteoporosis medications. What you're referring to are more the bisphosphonate category of medications. Those are still the most common. So Fosamax, for example, Zometa is another one that's an intravenous bisphosphonate. Those actually poison the osteoclast. They stop the osteoclast from breaking down old worn out bone. And so you've got the osteoblasts that are building new bone, but the deposition is not in a natural, healthy pattern. And so you can get the older bone that's laying around there, not being broken down, that becomes damaged and more fragile. And so you can see there is a phenomenon that occurs, a very small percentage of patients, but statistically significant. And there is a warning for this, is that people on the bisphosphonate medications and others can have an increased risk for what are called fragility fractures. And that is the bone becomes weak and it increases the risk for fracture. It doesn't decrease your risk. It actually increases your risk of a fracture. And when that happens, they're non-traumatic fractures. I mean, you don't even have to fall. There are cases in the research where, one woman, she was watering her plants, stepped down from a step stool, just turned to move to walk out of the kitchen or where she was, and her femur fractured. And she didn't fall. Now, like 95% of fractures occur because somebody falls. So that's the bigger risk than the side effects from these medications. But you're right in the sense that there is a group of medications that do not stimulate the natural or mimic the natural way that bone is created and produced. And the bisphosphonates are that category. Now, there are other category of medications called the anabolic medications like denosumab, Xgeva, Tymlos. Those are newer medications that they have different mechanisms of action, and they stimulate more osteoblast activity. Or there's parathyroid hormone analog like Forteo, which is a very old medication, which stimulates the deposition of bone. It's not poisoning the osteoclast. So those details and the nuances of how the medications work are really important to understanding, what's going to be best for them if they decide on a medication and what the safety profiles are. But there's also a risk both from denosumab and from the bisphosphonates of osteonecrosis of the jaw. And that is where, with something as simple as a tooth extraction, bone just begins to disintegrate. And it's a very difficult situation to stop and to treat. And so the dentists now, they want people to stop taking some of these medications before they'll do any dental procedures. And again, just having, the bigger picture about the potential benefits and the potential risks are important. But there are potential benefits to the medications as well. Like breaking a bone is dangerous. So with your medical history, if you have fractured a bone with osteoporosis before, the medications are much better at preventing a future fracture, right? So knowing that and making the decision is really helpful for understanding, the entire picture.
Yeah. No, thank you. It is. And I'm sorry I keep coming back to this. I just think this is one of those scary moments where the meds are just quickly offered. And most individuals sitting in that office don't know to ask these questions. They don't know their risks. And especially, again, if younger, and then you're going to be on these for 30 to 40 years.
You can't be on it that long. So there's sequential treatment. So the recommendation now is people should not be on bisphosphonate medication for more than, I believe it's 3 to 5 years. And then they switch to another one. So that's why, in the book, again, I counsel people and I recommend they ask their doctors, okay, what happens next? So you're recommending this medication, but I'm not going to be on it forever. I can't be. So what happens after that? And then what happens after that? And the research shows that once you stop the medications, the bone density goes down again. And so really understanding that is important for getting the whole picture, not just about the risk of the medication, but what happens over time. How is this going to be managed 3, 5, 10 years from now? And are you willing to commit to that?
Right. And this is where I love that you go, okay, maybe we'll see if medication comes into your future, but we're going to talk nutrition first. Let's also talk fitness for a minute. What are your recommendations around movement?
Do it. Move your body.
Just do it.
Well, it's not really complicated. And I'm a pretty simple guy. The research is clear. Even just walking 7,000 to 7,500 steps per day is associated with 50 to 70% reduction in all cause mortality. So there are these recommendations to go pump iron in a gym, and not everybody needs to do that. And in fact, it can be dangerous for some people. It has to be done safely. So the first question I ask is it safe? And is it effective? And by effective, I mean, has it been shown to reduce fractures ideally? All cause mortality is a great surrogate marker for that. And has it been shown to improve bone density if neither of those data points or results exist? So what we know is that I can't take somebody who hasn't exercised in 20 years as a couch potato and tell them to go get a gym membership and start pumping iron if that's not what they're interested in doing. It's just not going to be sustainable. Exercise, like diet, has to become a habit that somebody's going to do week after week, month after month, for years to get the longevity and the benefits, the bone benefits that we want. And so having somebody forcing them to do something they don't want to do is, to me, is a recipe to make them miserable and to have them fail and then beat themselves up and get more negative. And nobody needs that. It's just not helpful. And it's not necessary. So I like to meet people where they're at. And the research is clear. Once somebody starts doing something healthy, whether it's starting to follow a new diet or starting to exercise, and they continue doing that for a little while, they're more likely to start doing other healthy behaviors. And so I want people to have these wins, meet people where they're at. Even if it's just getting a friend and saying, let's go for a walk a few times a week. If that's where you need to start, great. I'm all for it, because this is about the long term, not about some short 2-month or 3-month marathon.
It's so good. You and I are so on the same page, and I so appreciate the small baby steps and the meeting people where they are in real life, because we both know that I love the fear factor is not motivating. To put somebody fear in front of them to motivate it, nope. And to put something that they don't like. Why would we ever do something day in and day out if we don't even like it in the first place? So finding those things that are sustainable is key. Oh, so good. What am I not asking you that you're like, your listeners need to know this?
Oh my goodness. That's a great question. So first I would just say about the education piece around exercise is that you don't have to stick with one thing forever. If you think you're going to like something, experiment just like you might with food. Try different foods, try different exercises, see what you like. But if you get bored with it, it's okay to change. There's so many options out there. So don't pigeon yourself like this is what it has to be forever. This is a fluid process. There's tons of options. Find out what's exciting for you or what makes sense for you, because I guarantee you there's probably something that's going to improve your bone health, reduce your fall risk, reduce your fracture risk by doing those activities. Again, it has to be safe first and foremost. I think one thing that's often overlooked that we haven't discussed is community connection. That is in my book. I've never seen it in any book. And what we know is that people who are connected in their community, who are involved in their community, first of all, live longer, they live healthier. But what the research has also shown is that people who have strong social networks, strong connections, if they do fracture, they heal faster. And so that's really an important piece. And my speculation in the book of one of the things that I think is happening is oxytocin. So when people talk about hormones, we haven't talked about hormone therapy. When they think of HRT for bone health, they oftentimes just think about estrogen and progesterone. For men, testosterone. But there are a lot of other hormones. Oxytocin is one of those hormones. Serotonin, we already mentioned, with the medications. There are serotonin receptors on bone. That's why those medications that increase serotonin are so dangerous to bones, because they stimulate those serotonin receptors in bone that increase the osteoclast activity and actually elongate or help the osteoclast live longer. So the osteoclasts are living longer and they're more active to break down bone faster. Well, oxytocin has the opposite effect. Oxytocin is our hormone for bonding and safety and love. Osteoblasts, they secrete their own oxytocin, which when I found that out, my mind was blown. And there have been animal studies done where they've injected oxytocin and their bone health was better. There are studies that have been done where women with osteoporosis have lower oxytocin than women without osteoporosis. And when you're connected in community and you have purpose, or connected with other people, that oxytocin is flowing, and that safety hormone. And I think that's one of the mechanisms that explains that. But that's one piece of this puzzle that I think is often missing. That to me, it kind of goes back to that. I don't know, frankly, where this came from, but I've heard it over the years. There's a proverb that apparently came out of somewhere in Africa. I tried to trace the origin. I wasn't able to. That if you want to go fast, go alone. If you want to go far, go with others. And I think this is a great example of that.
So good.
This entire approach.
Yes. Oh, I love that. That will go in the show notes. I'm like, I can just picture people listening going, I need more. I need these. I'm guessing your book, The Fracture Proof Your Bones, is one of your best ways to really start to understand you and all that you have to offer. Do you have other places, spaces that you encourage people to go to follow you?
Yeah. So the book, Fracture Proof Your Bones, expanded and updated edition, to me is the primary resource for people wanting to tackle this issue, because it's got the research, it's got my approach that I've worked with patients for 2 decades with. And the reason I wrote it is because I kept getting questions from people, from clinicians, from general public about what to do. And I can't be everywhere, of course. And so getting this out to people was really a labor of love, and saying, look, follow this. It'll help you create a holistic bone health program that makes sense for you. Improve your conversations with your doctor so you can be more of a partnership. And it's been very well received, I'm happy to say, both by clinicians and in the general public. Beyond that, there's my website, nbihealth.com, where the book can be found. There are also plenty of free articles and resources on there. You can learn more about my work and connect there on nbihealth.com.
Okay, perfect. And again, I will put that in the show notes. I always like to wrap up with this. If somebody's feeling a little overwhelmed, they heard a lot today. If you're like, okay, take this away. If I could make sure you heard one thing out of me, what would that look like?
I think the best thing that I can say to people is take a deep breath. Understand that this is a serious condition, but it's not an emergency, that there's time to educate yourself and create a holistic bone health program that makes sense for you. And if my book or my work can be part of that for you, that would be an amazing honor for me.
You're phenomenal. Thank you so much for your time, your wisdom today, Dr. Neustadt. You're the best. We appreciate you.
Thank you. I appreciate it.
Mm.